Okay, we're going to talk about invasive monitoring. This is just a primer. We're going to do some more education where we get some hands-on, but this is just so you can overview and kind of see what we're talking about, so you're a little more familiar with the pieces of equipment that we're going to be using, that you're going to be using in the ICU before you actually get your hands on it. So let's go over some stuff just so you can see some stuff. We're going to go over some terms. When we're talking about invasive monitoring, this is all it is really pressure monitoring, where you're checking either a blood pressure or central venous pressure, or maybe you have a catheter in somebody's head and you're monitoring their intracranial pressure. Okay, so I'm not trying to scare you. That's just all the places we can do invasive monitoring. And so you might get a blood pressure here with a cuff, right? We do that all the time. But here we can put an arterial line in now, and we can get a second-to-second blood pressure, which is real important if you have vasoactive drips going, or if you have a critical patient that you want to watch very closely. So invasive monitoring, that's all it is. It's just monitoring blood pressure or a pressure somewhere in the body that's invasive. It's not external like a blood pressure. So when we talk about invasive monitoring, there's a catheter that we can put in anywhere. We're going to talk about where we're going to put those catheters first, and then we'll talk about the setup of how we connect the equipment to those catheters. The catheters we can put in are an arterial line. So anywhere you have an artery that we can put a needle in, which might be brachial, it might be radial. I put pedal arteries in for neurosurgery. We can put a femoral artery line in, arterial line in. So that's where you're going to be monitoring arterial blood pressure. Okay, art line, arterial blood pressure. That's what you're going to be getting. It'll give you a systolic and a diastolic on the monitor, and it'll be second to second. And if the blood pressure starts to fall, you'll see it immediately. There won't be a 2 or 3 minute delay in like what a cuff's going to do for you. Where you're checking blood pressure every 2 or 3 minutes, you're going to know immediately. So that'll allow you to titrate your drips quickly. All right. Also, we can put a catheter in a central vein. This is central venous pressure monitoring, CVP monitoring. People call this catheter, I don't have one right here, but the central line, a CVP line. Well, it's for central venous pressure monitoring. It's kind of a misnomer, but that's what we call it. That's so we can monitor central venous pressure. And so we might put that in a big vein here, the subclavian vein, or in the internal jugular vein, or in the femoral vein down here. So that will allow us to get pretty close to central venous pressure. So you can monitor the pressure, the preload on the right ventricle. Okay, in neurosurgery, you might put a catheter in somebody's head, down in their ventricle, in their brain, and then you'll hook up this same transducer, just like the one you hook up to the CVP or the one you hook up to the R line. It does the same thing. We'll talk about that in a minute. But you might monitor their intracranial pressure. Okay, that's just another example. In the ICU here, they monitor intra-abdominal pressure sometimes. You'll monitor compartment pressure in somebody with compartment syndrome. So this transducer setup works all the same. That's why I want to make sure it's very clear. If you just understand a couple things about how a transducer works, you realize, oh, we could put this anywhere in the body and figure out what the pressure is. And those pressures are useful to you as you learn more and more about what the normal pressures are supposed to be. So when we talk about a transducer, this is the setup that we're going to use when we hook up to an art line or to a central line to monitor arterial pressure or central venous pressure. Are we good? Okay, so this, when you say transducer, all the word transducer means is to change. So a transducer, all it does is change. That's all the word means. I'm going to show you what it means to change, or we're talking about when we're talking about changing something. But the basic, the basic way this works is, what it does is it converts a mechanical pressure signal into an electrical signal that you can see on the monitor. Okay, that's how simple it is. And so don't make it any harder than that. This is a real simple thing. So let's pretend this was my arterial line right here, and we put it in my artery right here. Okay, we're just going to imagine that's going to be in my artery. Okay, so as my heart pumps and it makes a pulse that you can feel right here, right? I have a pulse. Yeah, there it is. And so that pulse that I can feel with my fingers is going bump, 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 right? As the pressure from my heart increases cyclically, right? I can feel that pulse. That means the pressure in my artery is increasing, and then it's dropping off, but then it increases again. I can feel the pulse, and then it drops off, right? So there's a systolic and diastolic. I can't tell what that pressure is by feeling it, but I can feel the systolic, the pressure, right? The systole from my heart. So we put this arterial catheter in right here, and what that is, this is a needle, obviously. Again, we're going to shut it off to the patient, You always know which way the patient's side is, because that's the hard tubing, right? You can squeeze it and you can tell that's the hard tubing. Turn it off to the patient. That opens the transducer to air. We're going to pretend that we have this. Let's just set it in here. So you can see, okay, now pretend this is in my artery here, right? And you're the master. Do you mind? So we're going to zero this real quick. So the zeroing process is just a couple steps. You want to turn it off to the patient like we did here, okay? And then you want to go to your monitor. It says zero imbalance here. We're going to touch that, and it's going to say, do you need to zero? And yes, we need to zero, because we want to make sure this is as accurate as possible. It says zero calibration. It says right here, zero imbalance. So that means you have to touch this right here, and it'll take a few seconds. It says zeroing complete. That means you're done. We can go back to the home screen, but then you have to return your transducer back to normal. So that means you turn this back to where now fluid can go through here, the pressure can go through here, through the three-way stopcock, in this side, out that side, and down to the transducer, okay? This is a dead-end cap. You want to make sure you have these dead-end caps on, that there's no holes right there. You can see a little hole there, but it doesn't go all the way through, okay? The priming ones that come with this, I don't have one in front of me, but I think they're white.
Yes.
And those have holes. They're for priming. You want to change those out because you want to have this dead end cap on here. Don't crank on it. You just want to barely seat it, because if you crank on it, it'll fuse and you'll never get it off. Okay, now what this means is, drop your pressure. If it's zeroed, let's see. Okay, don't hook it up yet.
Okay.
If it's appropriately zeroed, we're going to re-zero it. If it's appropriately zeroed, this red line should be on the zero line. You can see it's a little bit below. So let's see if we can zero this again. I don't know how to zero it.
If you go to home.
Okay, there we go. So now you can see the red line is on the zero line. That means it's perfectly zeroed. I didn't even open it, but it was open there. Okay, so go ahead and, now Brittany's going to simulate a pumping heart. And this is the kind of waveform we should see. Well, not exactly the kind of waveform we should see, but basically you can see what she's doing here is she's pushing pressure, just like an arterial pulse would push pressure into the circuit, and she's bouncing her thumb like this, bump, 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 making a waveform up here. Okay, so that's all that's doing. You have pressures in your right ventricle, in your right atrium, that also are much lower than arterial pressure, obviously, and that'll show up as a waveform here. That'll be a central venous waveform pressure. What else do we want to discuss about this? Basically, it was just a setup, right?
Mm-hmm.
Okay, one of the big things, this is very cool stuff and it's fun to work with. One of the problems that that I've seen in my own practice is these can disconnect. So you want to make sure your connections are very, very tight, and you want to be meticulous about your assessment of this whole system. This, we didn't put the pressure back on either. This system, if it disconnects and you have it in an artery, what's going to happen? The blood is just going to pour out, and it'll just pour out on the floor. If you have your alarms off, your patient can bleed out. If your alarms are on, it'll alarm. It should be a high-grade alarm, like an attention getter, like VFib or something, that should get your attention and say, there's a problem here, come look now. And so you always want to make sure your connections are nice and tight, that you always restore everything. When you walk away from this setup, that you check everything, that the connections are tight, that the stopcocks are where they're supposed to be. There's several connections here that you'll get to play with. That this connection's tight, this connection's tight, that stopcock is open like that, so that it's connected to the artery, that it's taped down well or sutured in well. So this is something you're going to assess, just like you would assess your IV. You would assess the right fluid, you assess the tubing, is the pump set right, is it connected, how's the IV site look? This is the same thing. It's just that the risk is a little bit higher, because if it does disconnect, it can be a real problem. That's one of the safety things. Now, we're still hooked up, right? Can you hold that back to where the catheter was about at zero? Okay, now something that's interesting is, here's a rule that you can see, just the rule of hydraulics. This is what happens with hydraulics, and how the hydraulics affect the pressure on the transducer itself. You can see, let's see, where was I right about there? So it's right about zeroed. Brittany's hand was a little bit higher before. Yeah, a little higher when you're working with it, when you're pumping it. Bring it up. Okay, so just hold it right there. That's about zeroed. So if this falls off, what can we expect the pressure there to do? We can expect it to go up because this hydraulic pressure, this fluid column that's in here is going to be pushing down on this. So as you drop this down to the floor, see how the pressure comes up, or just hold it right where you had it. Yep, see how the pressure goes up? Okay, so Brittany's wrist is right here where we had it before. Now we're going to hold it up in the air above that site, and you can see how low the pressure goes. So now the pressure, the fluid column is trying to push down. There's higher pressure down here than there is up here. So that's why you want to have this zeroed. You want to put it in one spot. You want to level it with the phlebostatic axis, and then keep it there. And then, but if you adjust your patient's head down, that's going to change the pressure. If you adjust their head up, that's going to change the pressure. So you always want to keep in mind before you take your readings where your patient is in relation to this. And you'll be re-zeroing frequently just to make sure you're happy with the numbers, especially if the patient's pressure has been 120 and now it's 70. Oh, that could be real. You just want to start turning your drips up, your dopamine up, and that kind of stuff. You might, but you might want to check your system real quick, and maybe even take a manual blood pressure where you can. What else, Britt? Is that enough?